Hello. In this group of slides, we're going to be talking about schizophrenia. Uh, Schizophrenia is a psychotic disorder. It is one that has been confused many, many times with dissociative identity disorder. Okay. Before we go any further, let's compare the two and let you make sure that you understand the difference. With DID, the person acquires DID usually through some kind of severe trauma during their childhood. Schizophrenia, it is an organic disease or disorder. Uh, Schizophrenia can be treated with medication. DID cannot. DID responds well or responds to therapy. Schizophrenia does not. Uh, Schizophrenia and DID both are generally the individual is not a danger to themselves or other people. Now with schizophrenia, if they start decompensating and declining and have paranoid schizophrenia, then they can present some hazard to other people. Uh, let's go ahead and move on and talk about schizophrenia. First of all, you need to know what a psychosis is. A psychosis is when they have a break with reality. Okay? Now, break with reality, that can be hallucinations. Now, hallucination is a sensory experience in the absence of sensory input. It can hallucinations can happen in any of the five senses. So if they see something that's not there, if they smell something that's not there, if they hear something that's not there, these can all be hallucinations. That's another difference between DID and schizophrenia. When DID talks about hearing voices, they're internal voices. The schizophrenics will talk about hearing voices externally. Okay? Now, delusions, these are false beliefs. Your slide says strong, inaccurate beliefs that persist in the face of evidence to the contrary. Hallucinations respond to medication. Delusions will not. It's not good to openly confront a delusion because that will not change their beliefs. It just makes them dig in stronger and come up with more compelling rationale for why what they're saying is true. Now, schizophrenia, it says it's a pervasive type of psychosis. It's characterized by disturbed thought, emotion, behavior. That behavior can also include speech. Emil Kraepelin used the term dementia and I have a hard time with that second word there. So to describe the schizophrenic syndrome. Now I'm going to go over the different subtypes of schizophrenia that they used to have in the next set of slides. Now, Bleuler introduced the term schizophrenia, which actually means splitting of the mind. This can be where the misunderstanding about the difference that schizophrenia and DID are different, because we talk about split personality and people think that's the same as a splitting of the mind. The DSM-5, there's quite a few criteria for schizophrenia, 2 or more of the following that present for a significant portion of time during a 1-month period: delusions, hallucinations, disorganized speech. This can be derailment. This can be incoherence. This can also be a thing called word salad. Okay. Now, grossly disorganized or catatonic behavior. Negative symptoms, which would be something like a diminished emotional expression, uh, having a flat affect or a very, very blunted affect. For a significant portion of the time, since the onset of the disturbance, the level of functioning in one or more major areas, such as work, interpersonal relations, self-care, is markedly below the level achieved prior to the onset. Continuous signs of this disturbance persisting for at least 6 months. That it is not schizoaffective disorder or depressive order or bipolar order with psychotic features. The disturbance is not attributable to the physiological effects of a substance, some kind of a drug that a person's taking or a medication they're taking. If the person has a history of autistic spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month. Positive symptoms. We talk about schizophrenia having positive and negative symptoms. The positive symptoms, that's going to be your hallucinations and your delusions. Active manifestations of abnormal behavior and distortions or exaggerations of normal behavior. Delusions. This is false beliefs. Now, it's also a gross misrepresentation of reality. The most common delusions are delusions of grandeur and delusions of persecution. Believing that people are doing things to them, that they are deliberately trying to hurt them or set them up or do something to them. Delusions of grandeur, where they believe that they have a tremendous amount of fame or power, that they're God, that they might be the president, but some kind of position of power or fame. Hallucinations, I've already told you, that's experiencing a sensory event without the actual sensory input. It can involve any or all senses. The most common is auditory. And findings from the SPECT studies says that the neuroimaging part of the brain most active during auditory hallucinations is Broca's area, which is involved in speech production. Remember, we talked about Broca's area in the biological chapter. And you can see Broca's area here on the left part of the brain there. Negative symptoms. This is the absence or insufficiency of normal behavior. Spectrum of negative symptoms, avolition or apathy, which is a lack of initiation, a lack of persistence. Alogia, a relative absence of speech. Anhedonia, we've talked about this one, a lack of being able to experience pleasure. Affective flattening. Affective flattening is no expression, no expressed emotions. Blunted affect, there's little expressed emotion. Disorganized symptoms include confused or abnormal speech, behavior, emotion. Then there's disorganized speech. There's cognitive slippage, which is illogical or incoherent speech. Tangential, I can't, I'm having a hard time today, folks. Tangent, going off on a tangent, okay? Loose associations, conversion in unrelated directions. The nature of disorganized affect, inappropriate emotional behavior, nature of disorganized behavior. This includes a variety of unusual behaviors. Now, catatonia is an interesting type of behavior. They can either be exceedingly excited, or they can withdraw so much into themselves that they will become frozen. Their positioning will become frozen. We call it waxy kind of modeling, because you can actually take an appendage like an arm and put it in a position, and they'll hold it there forever until somebody moves it another way. It's considered a psychotic spectrum disorder in its own right, but when it occurs in schizophrenia, it is a symptom. Schizophrenia was previously divided into subtypes. Like I said, I'm going to cover those in my next set of slides. There is no longer the case in DSM-5, but outdated terms are still in partial use. Included are paranoid, catatonic, residual. Like I said, I'm going to talk about those in a minute. Schizophreniform disorder. The psychotic symptoms will last between 1 and 6 months. If it's less than 6 months, then they will be looking at schizophrenia. A brief psychotic disorder, these are psychotic symptoms that last less than 1 month. Now, both disorders can be associated with relatively good functioning. I'm going to go ahead and just have this up here for a second or two, and that way you can pause it and look at the criteria for schizophreniform disorder. Because I want to go ahead and move on. Brief psychotic disorder, it has to have a presence of one or more of the following symptoms: delusions, hallucinations, or disorganized speech, or grossly disorganized or catatonic behavior. You're not supposed to include a symptom if it is culturally sanctioned. Okay? A duration of an episode of the disturbance is at least 1 day, but less than 1 month, with eventual full return to premorbid level of functioning. The disturbance is not better explained by major depressive or bipolar disorder with psychotic features, or another psychotic disorder such as schizophrenia, catatonia, and is not attributable to the physiological aspects of a substance. Schizoaffective disorder, symptoms of schizophrenic plus an additional experience of a major mood disorder such as depression or mania. Psychotic symptoms must also occur outside the mood disturbance. Prognosis is similar for people with schizophrenia, and such persons do not tend to get better on their own. Again, the criteria for schizoaffective disorder, I'm just going to put the slides up there for a second or two, and you can pause them and look at them. Delusional disorder. These are delusions that are contrary to reality. They lack other positive or negative symptoms of schizophrenia. That can be erotomania, grandiose, jealous, persecutory, somatic. Delusional disorder is extremely rare, but it has a better prognosis than schizophrenia. Criteria for the delusional disorder. Catatonia. This is unusual motor responses, particularly immobility or agitation or odd mannerisms. This is a very severe type of condition, but it's quite rare. It can be present in psychotic disorders or can be diagnosed all by itself. Some of the ways it can present is by stupor, mutism, maintaining the same pose for hours. That's that waxy flexibility I was telling you about. An opposition or lack of response to instructions, repetitive, meaningless motor behaviors, mimicking others' speech or movement. Psychotic disorders due to other causes. Psychosis may occur as a result of substance abuse, some medications or medical conditions. My ex-fiance was admitted to one of the local hospitals when we were engaged because he had taken so many drugs, he was having a psychotic break. Knowing these causes is important for treatment. You have to address the underlying cause, okay? And it can include substance or medication-induced psychotic disorder or a psychotic disorder associated with another medical condition. Another set of slides. Schizophrenia statistics. Well, about 0.2% to 1.5%, or approximately 1% of the population, has schizophrenia. Now, usually you're going to see schizophrenia occur sometime between the mid-20s and the 40s of an individual. But it can emerge at any time. Childhood cases are extremely rare, but they can occur. Schizophrenia basically is a very chronic, severe mental illness. Most will suffer with moderate to severe lifetime impairment. The life expectancy of a person is going to be slightly less than average. They do have an increased risk for suicide, an increased risk for accidents, and they tend to take care of themselves less efficiently. Schizophrenia affects males and females equally. Females tend to have a better long-term prognosis, though, but the onset is slightly earlier for males. Now, here's something that's not on your slide. If an individual starts smoking marijuana in their youth, say childhood, or in their teens, if they are predispositioned toward schizophrenia or a psychotic disorder, it will bring it on significantly faster. Okay? Cultural factors, you have to be careful because sometimes what we consider psychotic behavior or unusual or pathological behavior may be quite acceptable in another culture. Okay? Schizophrenia is found at similar rates in all cultures, though. The course of schizophrenia, of course, is basically they will stabilize but then decompensate as they go along and then basically stabilize some more. Causes of schizophrenia. Well, there tends to be a family risk factor, a family gene that occurs with schizophrenia. Now, if a person has a parent that has schizophrenia, if I'm not mistaken, they have a 25% risk factor of developing schizophrenia. The risk increases with genetic relatedness. For example, having a twin with schizophrenia will incur a greater risk of having than having, say, an uncle with schizophrenia. Linkage and association studies about genetics. Well, endophenotypes, the schizophrenia is more likely to involve multiple genes. Behavioral markers, smooth pursuant eye movement. Schizophrenic patients will show a reduced ability to track moving objects with their eyes. Relatives of schizophrenic patients also have deficits in this area. Also, there's what's called a schizophrenic shuffle, and they tend to have a distinctive type of walk as they decompensate. Causes. Well, we know that a person who has schizophrenia will probably have an increase in dopamine. And so the dopamine hypothesis says that schizophrenia is partially caused by an over amount or an overactive dopamine. Drugs that increase dopamine will result in schizophrenic-like behavior, and drugs that decrease dopamine reduce schizophrenic-like behavior, such as neuroleptics. The problem is that is not a cure-all, and it's oversimplistic to say that's all we need to do, or to look at it and say that's explains it. There are structural and functional abnormalities in the brain of schizophrenics. They will have enlarged ventricles and reduced tissue volume. The hypofrontality, they will have less active frontal lobes, which is a major dopamine pathway. And viral infections during early prenatal development is another suspected cause, but we don't have anything definite on that. The findings are inconclusive. Marijuana also increases the risk for developing schizophrenia in at-risk individuals. That's what I was saying a minute ago. All right, so conclusions. Schizophrenia reflects diffuse neurobiological dysregulation. Structural and functional brain abnormalities are not unique to schizophrenics. Stress can be a trigger. It can activate underlying vulnerability. It can also increase the risk of a relapse. Family interactions, if they have these are unsupported theories, whether if they have a schizophrenic mother or double-bind communication, that can cause schizophrenia. If they have a high expressed emotion, that's associated with relapse. Other psychological factors may function as the diathesis and a diathesis stress model. And the role of psychological factors exert only a minimal effect in producing schizophrenia. Now, with all that said, I'm going to give you one other story here that kind of blew my mind when I was in grad school. We were told about a psychologist named Milton Erickson. Now, Milton Erickson was a very, very well-respected psychiatrist, and he was just a phenomenal doctor, and was able to do things that other people were not able to do. There was a patient that was decompensating. He had schizophrenia, and he was not able to, he was not making any progress. And the medical personnel didn't know what else to do. They had tried everything to help this fella, and so they called in Dr. Erickson. Dr. Erickson came in, and this is my understanding. He came in, hold on, I'm running out of battery juice. Sorry, sorry, sorry. Dr. Erickson was called in, and they asked him to look over the case. When he did, the first thing he did was tell them that they needed to record everything that this guy was saying. Now, he was saying what's called word salad. Word salad is when you put words together that make no sense. That they will make sentences that have no. It just doesn't mean anything. Like they might talk about the cars, desk, blue, joke, 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 sad. Something like that. It doesn't make a lot of sense, okay? Now, I'll give you some other examples of word salad in a few minutes. But anyway, he had the personnel write down or record everything this guy said for 24 hours. Every bit of that word salad. Now, first of all, that would have really, really surprised me, because to have somebody sitting there and making sure that every bit of this was recorded, I mean, that's kind of a grueling task. But, now this is really going to blow your mind. After the 24 hours, he got the information, and he sat down and he looked at it and he analyzed it and looked at it and analyzed it. And then he said he figured it out. And so he went and he sat down beside this guy outside one day when the guy was just sitting on a bench, and the guy looked over and said something to him in word salad, and he looked back and he said something back in word salad.